So welcome to a EMT quiz. I know I don't do a lot of EMT content on here, and that's about to change. I'm going to be doing a lot more EMT quizzes like this, and I'm also going to be doing a lot more EMT lectures. So if that's something that you think you or someone else that you know might benefit from, send them over. Let's get after this. We got a 25-year-old unrestrained female struck her chest on a steering wheel during a high-speed crash. She presents with hypotension, tachycardia, and signs of internal bleeding in the chest. Which intervention offers the best chance of survival? Would it be A, rapid transport to a trauma center, B, intravenous fluid administration, C, full spinal immobilization, or D, high-flow oxygen administration? Now, as an EMT, whenever you're sitting for an exam like this, occasionally come across answers that aren't even in your scope of practice. For example, B says intravenous fluid administration. We can go ahead and throw that one away. What's your index of suspicion here? We had a high-speed crash. This person's hypotensive, tachycardic, and we know that there's internal bleeding in the chest. This person needs a surgeon. As an EMT, there is literally nothing that you can do to save this person other than getting them to the hospital. Literally, that's it. So if it said, what would you do initially? Maybe spinal motion restriction would be the answer. But what is it asking from us? Which intervention offers the best chance of survival? Rapid transport to a trauma center is definitely the answer. Let's look at the next one. A 56-year-old male is found semi-conscious with rapid shallow respirations, irregular rapid pulse, and hypotension. His wife says that he had left arm pain and nausea yesterday, but refused to seek care, which is the most likely cause. So before I even look at answers, by the way, this is a way that I take exams, and this is a way that I recommend you to take exams. Don't just immediately look at the answers. Let's think about what was asked. So we know that this person has rapid shallow respirations with an irregular rapid pulse and hypotension. This person is sick. Not only is this person sick, but they are unstable. Like, this person is fixing to die. His wife says that he had left arm pain and nausea yesterday. Those sound like very classic ACS, acute coronary syndrome symptoms, right? And if you know anything about ACS, that's a heart attack. So be mindful when you see adjectives like this, left arm pain with nausea. Some other things I could have looked for is Levine sign, where they're clutching their fist on their chest, maybe chest pain that's radiating to their jaw, things of that sort. But now let's go ahead and look at these answers. First one's a ruptured aortic aneurysm. B is septic hypoperfusion. Interesting one. C, severe dehydration from illness. And then D, acute myocardial infarction. Now, a ruptured aortic aneurysm could be a potential one here if they started using the terms like tearing chest pain, rapid onset. What do we know about this onset? It's gradual. His wife says that he had left arm pain and nausea yesterday. So this has been ongoing, right? Because it's ongoing, I know this is not A. B, septic hypoperfusion. It says nothing here about pointing me into sepsis. So I don't see any fever. I don't see anything about the patient fighting an infection, anything of that sort. Severe dehydration from illness. Again, it's just not painting the picture for me. Acute myocardial infarction. That is definitely the best answer here. Number 3 says, we have a sudden fainting episode triggered by emotional stress is most consistent with. So have you ever seen one of those goats where they scare the goat and it freezes and passes out? Or have you ever watched any videos of people on circus rides and they pass out just because of the excitement or the terror of being on that ride? Well, yeah, that's called psychogenic shock, when this emotional stress causes all their blood vessels to vasodilate and they actually lose blood flow in their brain, and that causes them to pass out. So just telling you what that is C. If it was neurogenic shock, that would have to be something, actual damage to their spinal cord, central nervous system, where it would cause widespread vasodilation throughout their entire body. And also it would cause bradycardia, so their heart rate would be lower. Vasovagal means that somebody strains. That causes a parasympathetic response. So their nervous system actually makes their heart beat slower. And typically we see that with elderly patients that are going to the bathroom and they are straining on the toilet and they pass out. That's a vasovagal. And then D, neurologic shock is not a term that we use. It's neurogenic shock. So that one is just there to confuse you. C, that's our answer. When assessing a patient with suspected shock, which statement is most accurate? Now, obviously, we don't have enough information to just start guessing on answers. So we need to look at the responses here. We got A, multiple fractures are the most common hypovolemic cause. That's bizarre. B, BP is often the last vital sign to change. Decent answer. C, respirations are deep in early shock. And then the last one here is irreversible shock responds well to a transfusion. It's irreversible shock for a reason, right? So definitely not D. When it comes to shock, blood pressure might not be the last thing to happen, but it is something that occurs in decompensated shock. If I see a blood pressure that is dropping, this means that this person has been progressing through shock. And this is why B is definitely the best answer in this test question. Let's go ahead and select that. Oh, we got our first select 2 here. Yes, the National Registry does have select multiple answers. It states here, which conditions are common causes of cardiogenic shock? Select 2. Be careful with a test question like this. And why do I say that? It's asking what conditions cause cardiogenic shock, not what symptoms are found in cardiogenic shock. So I'm just telling you now, a lot of students would get this question wrong specifically. And looking at these answers, I'm going to show you how I'm going to answer this. Common causes of cardiogenic shock. First off, I think you need to understand what cardiogenic shock is. To have shock, there needs to be one of 3 things that is failing. It's either you're losing blood or volume. Okay, the blood vessels are not doing their job. Blood vessels are supposed to be moving blood, but if all your vascularity vasodilates and slows down or stops moving blood, then your patient will go into shock. And the third one is if your pump stops working appropriately. And that's exactly what's going on in cardiogenic shock, where we have somebody's heart who's not doing its job. I'm looking here at different things that might make the heart not work well. And the first answer here is an increase in afterload. Now, understand, you're in EMT school, maybe you're really good with medical terminology, maybe you're not so good with medical terminology. Let me explain to you what afterload is real quick. Afterload is the amount of pressure that the ventricles of your heart are going to have to beat against. So if we think of systemic circulation, just past your heart is the aorta. The aorta is like the size of a garden hose. It's a very large blood vessel that wraps around your chest, down into your stomach, and then forks into your legs. In that aorta, there's going to be pressure, right? Because there's blood flowing through your entire circulatory system at all times. And your heart has to push against that pressure to get blood out of the ventricles. Well, guess what? That pressure that the heart has to beat against is called afterload. So think about this with me. If we increased the afterload, we made the pressure greater, what would happen to your heart? Your heart would have to work harder. Your heart's a muscle. What happens when you work out and you have to work hard to do something? Can you do it forever? No, you can't do it forever. Same thing with your heart. It will go into cardiogenic shock if you increase afterload and don't give your heart a break. Right off the rip, great answer. Another common cause of cardiogenic shock, it states here, B is angina. Angina just means chest pain. And oftentimes this chest pain is occurring due to lack of oxygenated blood flow that goes to the heart. And can that cause a failing of the heart? Yeah, absolutely. But just because somebody has angina does not mean that they are going into cardiogenic shock. So I'm going to put that one on the side. If the other answers are terrible, then yeah, we're going to go in and pick angina. If it didn't say angina and it said like acute coronary syndrome or it said an MI, yeah, that would be a great answer. But just angina, nah, not the best answer. Next one here, we got increase preload. Increasing preload just means supplying more blood flow to the heart. Now, we can all agree that if you do increase preload, there will be an increase in oxygen demand from your heart because your heart's going to have to work more to push out the blood, right? So there is an increase in preload. An increase in afterload is much worse for that heart than this increase in preload. So I'm also going to put that on the side here. So far we have some decent answers. And then the last one here is poor contractility. Man, poor contractility is cardiogenic shock. Which conditions are common causes of cardiogenic shock? Absolutely. Poor contractility has to be an answer here because that will cause cardiogenic shock. And if you don't understand what contractility is, it's the actual strength of which the heart is able to squeeze. And remember, every single time that the heart contracts, it pushes blood. And we call that stroke volume, the amount of blood that's pushed with every single contraction. So if we have poor contractions, then we have poor contractility. And if we have poor contractility, then we're going to have a decrease in cardiac output, the amount of blood that's actually going into systemic circulation. I know some of this might be a little heavy, and I hope this is making sense to you. But yeah, that's going to be the other answer I pick here. We got another select two, which are hallmark features now of cardiogenic shock. So now we have a good understanding of what is cardiogenic shock. A says high cardiac output. We just had that conversation. Absolutely not. Terrible answer. B says impaired ventilation. Great answer. Let me explain why. If a patient has cardiogenic shock, this person has failure of both sides. And if you know anything about the left side of the heart, the left side of the heart is where you're getting this oxygenated blood flow from your lungs. Well, if your heart is failing, if you have left-sided heart failure, that blood is going to back into the lungs. Patients that have pulmonary edema or this fluid or this backup of blood into their lungs, they struggle to breathe. They have impaired ventilation. Remember, ventilation just means the act of being able to move air in and out. And this is a problem with cardiogenic shock patients. One thing that I like to tell students is, do you understand what CHF is? And most of the time they say yes. I say a cardiogenic shock patient is your CHF patient with a low blood pressure. So whenever you think of that patient that's tripoding with a short inhalation, short exhalation, tachypnic, this person's really struggling to breathe, and now you make them have a low blood pressure, that's what we're dealing with here. So definitely I'm going to pick B. C has to be an answer. Pulmonary edema, right? We just talked about that. So it has to be an answer. And then D, warm and dry skin, absolutely no. This patient will be cool and clammy. Next question, which is the best way to reduce fatigue and maintain CPR quality in a two rescuer scenario? So we have a BLS, kind of like American Heart Association type question. Answer 1 says switch when one rescuer feels tired. Not the worst answer in the world, I'll be honest with you. Never continue doing CPR if you feel too tired. If you can go in and pass it off to another partner, do so. Well, let's see what else we got. B says switch roles every 5 minutes. Nope, we ain't picking that. That is not a part of American Heart Association. Remember, American Heart, we switch every 2 minutes. Change only when instructed by an ALS provider. Now that's crazy as well. And then D, rotate compressors every 2 minutes. So A and D are our best answers. But the problem with A is that if that was the case, some people would go past the 2 minute mark. They're like, hey, I'm not tired yet. I'm going to keep doing chest compressions. And that is incorrect. We want to switch or rotate compressors every 2 minutes. That's why D is the best answer. Next question. Which are correct compression to ventilation ratios? Select 2. A says a child, 2 rescuers, 15:2. Absolutely. Now, one thing with kids or children, whenever we're talking about ratios, kids and infants, the ratio is always going to be 15:2 for those age groups. And the reason being is we want to ventilate those kids twice as often. Please understand that. If you are by yourself and you are managing a child or an infant, you're going to be doing 30:2. The reason being 30:2 is because there will be too much delays in compressions. If you had to get up, move over, breathe for them, get up, move over, do chest compressions, there's too much moving around if you did 15:2 and you were by yourself. So 30:2 if you are by yourself for any age, except for newborns. But we'll see if we get into any test questions like that. But looking at this, Yeah, child, 2 rescuers, 15 to 2. And remember, adults never change. I don't care if you're with 30 people on that call. If you're with an adult, it's always going to be 30 to 2. If you're by yourself, it's always going to be 30 to 2. And I could already see it right here in B, 30 to 2. Let's look at these other ones. Infant, single rescuer, 15 to 2. I explained why that's bad. And then adult, 2 rescuers, 15 to 2. We all know that's incorrect. Which is the most common cause of cardiac arrest in children? Would it be a congenital heart defect, ventricular fibrillation, respiratory failure, or myocardial infarction? If you know anything about kids and cardiac arrest, the number one thing that causes death in kids is respiratory. Now, do some kids die with congenital heart defects? Yeah, absolutely. But more kids die every year because of asthma, anaphylaxis, choking, drowning. There's so many different ways that a child can die because of a respiratory problem. That is why C is by far the best answer there. What's the recommended compression rate for adults during CPR? We're talking about rate here, how fast. And this guideline was updated in the 2020 guidelines. It's 100 to 120 beats per minute. Next question. When using an AED on a pediatric patient, select 2. Here we go. Use pediatric pads if available. Great answer. I'm just going to go ahead and pick it right off the rip because that's a great answer. B, use adult pads only if the child is under 1 year of age. Terrible answer. C, never use AEDs in peds. And then last one, ensure pads do not touch each other. That is absolutely true. We never want to let pads touch each other. Pads should always have a pad to skin contact. And if you have pediatric pads, use them whenever dealing with kids. But if you don't have pediatric pads, we can still use the adult pads. We just have to use the anterior, posterior pad placement on the front and back of the kid. Next question states a medication patch is found under the intended AED pad site. What's the correct action? A states delay AED use until EMS arrives. B, move the patch to another location. C, remove the patch and clean the skin. And then D, apply the pad over the patch. Listen, like I stated in the last test question, we need to always have a good pad to skin contact. This is considered a special consideration with the American Heart Association. There's several special considerations. One of them being medication patch, hair on the chest, patient's skin is wet, patient has a pacemaker. So there's different things that we have to consider whenever placing pads onto a patient. If we ever find a medication patch on the patient is in cardiac arrest, and it could be because of that medication patch. We always want to remove the medication patch and clean the skin before placing that pad. This is why the answer is C. B was a funny answer though. Another select 2 here. Which are valid reasons to stop CPR? Select 2. A says a bystander asks you to stop. That's a great answer. No, it's a terrible answer. Do not pick that. B, you are physically exhausted. Yes, that is a reason why we would stop. If you are physically exhausted and you feel like you're going to pass out, remember your safety as the provider is the most important thing. Remember, you just being exhausted and unable to perform is just putting yourself in jeopardy. C states return of spontaneous circulation. We call this ROSC. And ROSC is definitely a time when we would stop doing chest compressions. If your patient has a pulse, which remember we assess a pulse every 2 minutes, you should stop doing chest compressions. We do not need to continue them. The last one says you note agonal respirations. Believe it or not, the term agonal respirations in cardiac arrest has not been something that has been talked about forever. It's been much more of a topic over the last decade or so. If you note that somebody has agonal respirations like this erratic breathing or a snoring sound, that does not mean that they're alive. I would recommend for you to check a pulse on somebody if you ever note agonal respirations, because they may have went into cardiac arrest. But if you're working a code and somebody has agonal respirations, it doesn't mean they're alive. Next question states you respond to a 68-year-old female who had collapsed at a grocery store. She's pulseless, apneic, and while performing chest compressions, your partner prepares the AED. Which of the following is the correct sequence for AED use? Now, before I even look at these answers. Let me explain something to you about the AED. The first thing that you will always do with this AED is turn it on. The AED is going to tell you exactly what to do. I would never open up an AED and just start placing pads on somebody or doing anything else other than turning on the AED, letting it run through its original entry or initial prompts, and then it will tell me when to place pads onto the patient's bare chest. And guess what? If I don't follow it, what do you think the AED is going to say? Place pads on patient's bare chest. Place pads on patient's bare chest. It's going to keep saying that until you do it. So let's look at these answers. A says attach the pads. We're not picking that. B says turn on the AED, then attach the pads, then analyze the rhythm, then deliver the shock if advised. That is the perfect order. And just looking at these first things for each answer, B was the only one. That test question was too easy because of that. Our first select three. Which of the following actions are considered high quality CPR for an adult patient? Select three. Obviously, we got to read through these to figure this one out. Ventilation rate of 6 to 8 breaths per minute with an advanced airway. Old school, man. We haven't done 6 to 8 breaths per minute in an advanced airway in probably over 10 years now. So that answer is wrong. B, compression rate of 80 to 100. We all know that's wrong as well. C, allow full chest recoil after each compression. Great answer. Whenever we're performing CPR, we want to do it on a hard, flat surface, and you always want to let that chest go to a neutral position. We call this full chest recoil. This allows the heart to fully expand back to its normal position before we push down on it again. Allowing for full chest recoil is always a great idea. Never put all your body weight on that patient's chest and leave it there, because you will never get that recoil. D says avoid compressions over the lower third of the sternum. That's where we want to place our hands, the lower half of the sternum. We got E, compression depth of at least 2 inches. Great terminology there. In 2020 guidelines, that actually changed. It used to be we would push 2 inches. Now it's we push at least 2 inches. And then the last answer there, minimize interruptions to less than 10 seconds. And that is correct as well. You never want to interrupt chest compressions for more than 10 seconds because your perfusion pressure within the blood vessels and in the brain drops down to 0. What they say, it can take up to around 16 chest compressions to get back that perfusion pressure where you're actually pushing blood into vital organs. So minimizing chest compressions is a bad thing at all times. It's always a bad thing. Next test question says, a 9-year-old is found pulseless in a school gym. You are the first rescuer on scene and have an AED. Which is the best action? So let's go ahead and talk about this test question before I even look at answers. It's talking about a child who's found pulseless in a school gym. Now, honestly, there's not a lot of information in this test question for me to make very specific answers, right? Because if there are multiple people, am I by myself? Do I have my phone with me? Right? There's a lot of different variables that I would want to know in a test question like this. So I'm interested to see what these test questions state, because I know if I found this person pulseless, this is an unwitnessed arrest. I need to perform at least 2 minutes of CPR before I can go off and grab an AED. So let's see what it states. Wait for a pediatric pad for defibrillation. Absolutely not. B, attach pediatric pads if available. Use adult pads if not. Great answer. C, begin chest compressions only until ALS arrives. What? And then D, use adult AED pads immediately. Okay, so this didn't have anything to do with what I thought this test question was going with, but this is a great way to formulate your thoughts whenever you're sitting for the National Registry, to read a test question, really understand what it's asking, and I formulate a plan on how I'm going to manage this patient before I even look at the answers. But yeah, the answers here had everything to do with an AED, had nothing to do with the actual CPR or the care for this child, but that's okay. Next question states, a 54-year-old patient in cardiac arrest has an advanced airway in place. How should you deliver ventilations? So giving ventilations through an advanced airway is actually different than rescue breathing. And what I mean by that is rescue breathing just means I'm going to assist ventilations to somebody who is not breathing adequately. Whenever I assist ventilations or I perform rescue breathing, that's 1 breath every 5 to 6 seconds for the adult. If I am delivering breaths to somebody with an advanced airway, That could be an ET tube, a supraglottic airway. I'm going to be performing one breath every 6 seconds. There is no range, but understand that there is a range for pediatrics now. The 2020 guidelines, that got updated to one breath every 2 to 3 seconds for rescue breathing and for breathing through an advanced airway. But this one is obviously a 54-year-old male, so we know this is an adult. States here, 2 breaths every 30. Chest compressions, absolutely not. With an advanced airway in place, we're going to be doing asynchronous with chest compressions, 1 breath every 6 seconds. And obviously there in Bravo is exactly that. Something interesting, I just looked at D and I was like, wait a minute, 10 breaths per minute. So 10 breaths per minute is 1 breath every 6 seconds, right? So immediately that caught my eye, but look what it says. 10 breaths per minute with compression pauses every minute. It's like, what? That didn't make any sense. But be careful with that, with the whole math thing. Is the National Registry could say 10 breaths per minute or 10 to 12 breaths per minute for rescue breathing. So understand that 1 breath every 5 to 6 seconds or 1 breath every 6 seconds. Know how to calculate that as well. And if you are really bad at math, please know that in the National Registry, on the screen itself, they do provide a calculator. To respond to a 58-year-old male complaining of sudden chest discomfort radiating to his left arm. He's pale, diaphoretic, and SpO2 is 93%. What is the most appropriate immediate action? So there's a couple buzzwords going around in this test question. I'm going to point them out. The first one that I see is sudden. Whenever I see the term sudden in a test question, that is not there on accident. The word sudden or acute is there on purpose, and it's trying to point me in a direction. Let's see. Chest discomfort radiating to the left arm. Pale, diaphoretic. So right now, I was hoping that it was going to give me a little bit more information. But right now, just the fact that it's radiating to the left arm, he's pale and diaphoretic, this shows all the classic signs of an acute myocardial infarction. The whole thing about sudden onset of chest discomfort is a little bit concerning to me because I was starting to think possibly in aortic dissection. But let's take a look at some of these answer choices. Apply high flow oxygen via a non-rebreather mask. Begin chest compressions immediately. Place the patient in the supine position and wait for ALS arrival. Or D, assist the patient in taking prescribed nitro if indicated. This is a good chest question, I'm going to be honest with you. And the reason why I say that, the only thing that really threw me off was the term sudden, but I'm not going to let that ruin what I got going here. We have an SpO2 of 93%. Now, you might know that normal is between 94 and 99%. Well, I'm going to call this a potential for ACS, right? Acute coronary syndrome. And this person's having a heart attack. Because of that, I do not want to give this patient high flow oxygen unless they are hypoxic under 90%. This is a newer American Heart Association guideline. And the reason being is giving high flow oxygen to somebody will actually cause the blood vessels to constrict. And what do we know about heart attacks? Well, the heart is already lacking oxygen. If I constrict those blood vessels, what am I doing to the heart? I'm actually reducing the amount of blood flow that's going to the heart. And I could potentially make this heart attack worse with high flow oxygen. So the days of us giving oxygen just to everybody, those days are long gone. And with my ACS patient, I'm going to be only giving oxygen if that SpO2 is less than 90%. So I am going to not give A. B, begin chest compressions immediately is the most craziest answer I've ever heard. Absolutely not. C, place the patient in a supine position. That's just as crazy as B. No. D, though, says assist the patient with taking prescribed nitroglycerin if indicated. I love that it says if indicated, because if it did not say that in that last answer, I probably would not want to pick that answer. And the reason being is that the patient's pale and diaphoretic. And with patients that are pale and diaphoretic, they may be not perfusing appropriately. Obviously, this test question did not give me a blood pressure. So it's really hard for me to say, I'm going to go ahead and just give this guy his prescribed nitro. But the fact that it said if indicated, come on, that's a great answer. Going with it. So next question here we have, which of the following are common signs or symptoms of, again, ACS, acute coronary syndrome. And to start with diaphoresis, this is sweating. Sweating is very commonly seen in patients who are having a heart attack. And it's one of the first things that I note in my general impression when I'm walking up to somebody. Remember, not everybody is going to have the crushing chest pain that radiates to their left arm or into their jaw. There are 3 patients that have what we consider atypical chest pain, and that's our female patients, geriatric patients, and our diabetics. So if I ever come across these patients and I see that they're just very clammy when I walk up, it's usually a bad sign, and there is a chance of ACS going on. Next, we have dyspnea. Another great answer. Shortness of breath is often seen with acute coronary syndrome. Next answer is another great answer. Epigastric discomfort. Epigastric discomfort is lower chest pain, higher abdominal pain. This is something that is commonly seen in ACS. Let's look at some of these other answers just in case they're better than ours that we've already chosen. Hemoptysis means coughing up blood. Definitely not something that I'm considering when somebody's having a heart attack. Severe headache. Again, no. And then hypertension. None of these are common in ACS, but these top 3 definitely are. Select 2 here. You are assessing a patient with suspected heart failure. Which of the following findings support this diagnosis? A, right off the rip, crackles in the lungs. Crackles is what they consider an adventitious lung sound. Adventitious lung sound just means abnormal. So crackles is fluid in the alveoli, and that is something that we do see in left-sided heart failure. Productive cough with a frothy sputum. Interesting. Productive cough means mucus production in a cough. Frothy sputum is something that we often see with heart failure type test questions, but usually it'll use the term pink frothy sputum. So thought that was interesting that they did not there, and they used the word productive cough. Nah, I'm not going for it. JVD. Ooh, I'm going with that. JVD is something that is often seen with right-sided heart failure. Remember, the left side of the heart will always, if left untreated, will cause the right side of the heart to fail. Patients that have right-sided heart failure will cause an increase in pressure throughout your circulatory system. So you'll see JVD, and then you'll also see pedal edema. So the vascularity gets engorged, your venous system gets engorged with blood, and it can leak. And this is why we see JVD, like I said, and that edema. It's in right-sided heart failure. Pinpoint pupils, absolutely not. That has nothing to do with heart failure. And hypotension with warm skin, nah. Maybe cool and clammy. We can see that with heart failure, but yeah, hypotension with warm skin. By the way, with left-sided heart failure, I'm usually suspecting to see hypertension. So something to note. A 49-year-old male suddenly collapses at work. An EMT on scene begins CPR immediately. Thank God. You arrive with an AED and find him in pulseless ventricular tachycardia. How on earth do you know that? You got an AED with you. What should you do? Okay, so somebody collapses, somebody begins CPR. This is a witness versus non-witness type test question. At least that's where I think they're going with this. If somebody starts CPR immediately and I show up, we can go ahead and apply the AED immediately and defibrillate. Let's see what it says. Give 2 minutes of CPR before shocking. We're not picking that. Transport without shocking. Deliver a shock immediately and then resume CPR. Absolutely. Again, like I said, the fact that this was a witnessed arrest and somebody began CPR immediately is why I'm going to deliver the shock immediately. If it said that this person collapsed at work and then you showed up and you don't know how long this person's been on the ground, it was unwitnessed arrest, we would then do 2 minutes of CPR before we deliver that shock. Next test question, select 2. We're almost done, y'all. In which of the following situations is aspirin administration indicated in the pre-hospital setting? Aspirin administration. Suspected MI. I'm going with it. Patient with known aspirin allergy. Absolutely not. There are 2 reasons why we would never give aspirin. 1, they have an allergy to aspirin, and 2, they have bleeding in their stomach. We do not give aspirin to either of those patients. C, chest pain of unknown origin with suspicion of ACS. Great answer. I'm going for it. D, states stroke with active bleeding. And then the last one, patient with suspected pulmonary embolism. No, absolutely not. Believe it or not, some stroke protocols may advise EMTs to administer aspirin, but not if there's active bleeding. And that is very protocol dependent. I don't want you to just be throwing aspirin at people because you think they're having a stroke. We are giving aspirin because somebody is having chest pain, they're having an MI. And again, they cannot be allergic and they cannot have any signs of bleeding. What aspirin does in the blood is it prevents platelets from clumping. Remember, if you know anything about platelets in your blood, platelets bind together and create a clot. Well, if you give aspirin to somebody, it doesn't promote this clotting to occur. The platelets kind of bounce off each other. That's its job. Again, that last one, patient with suspected PE, absolutely not. Aspirin is not indicated for pulmonary embolisms. 64-year-old male is complaining of crushing chest pain that began 30 minutes ago while mowing the lawn. He's clammy, pale, and nauseated. Vitals 142/88, heart rate 96, respiratory rate of 20, SpO2 of 95. What should you do first? Love it. What do you do first? Is it A, assist with nitro? Don't do it. Is it B, begin rapid transport? Actually, not the worst answer, but I'm still not going for it. Apply high flow oxygen. I already told you, do not give oxygen unless that SpO2 is what? Less than 90. The last answer there, administer aspirin. Aspirin is the first line treatment for ACS. We're going for it. We can do that before we get this patient loaded up and before we hit the road. Give them aspirin. Just make sure you ask those 2 questions I told you about, and let's get out of there. A couple more test questions. Which of the following are common causes of cardiac arrest in adults? Select 3. Epiglottitis. What? No. B, ventricular fibrillation. Yes, that is cardiac arrest. So I'm thinking that's probably a very good answer. Let me see these other ones first. Hypovolemia. Definitely a good answer. Severe hypothermia. I would not say that that's common. Pulmonary embolism. Decent answer. And then hypoglycemia. Definitely not a common cause of cardiac arrest. We're going with these 3. I'll be honest with you. For me to think that pulmonary embolism is a common cause of cardiac arrest, I don't think it is. It's just not as common. I wish they would have had something here like trauma or, heart attack, things of that sort. But from what we were given, these are the best 3 answers. Remember, ventricular fibrillation is quivering of the ventricles. And that does not pump blood, right? So whenever there is VFib or VTAC, pulseless VTAC, that person's heart is not pushing blood, right? And that person is in cardiac arrest. Those are the best answers that I see there. And our last test question. You're caring for a patient with a history of angina who reports chest discomfort after climbing stairs. The pain subsides after rest. Which condition is most likely? Easy one, man. Easy way to end it. This person had chest pain or angina when they exerted themselves. They were climbing the stairs. It caused pain. Have you ever heard of a stress test? Like when they put an ECG on you and they make you run on a treadmill. What they're trying to see is if not only does it induce pain, exerting yourself, but if they see any ECG changes on that 12 lead while you're running, this is often a sign that your heart is reducing blood flow when there is an increase in oxygen demand, right? So when you're climbing stairs, your muscles are saying, hey, we need more oxygen. So your heart starts beating faster, it starts beating harder to try to push that blood to all your muscles. Well, if your heart can't keep up with the oxygen demand, then your heart starts to need more oxygen as well. And if it's not keeping up, it's going to start inflicting pain to your patient. But guess what? If that pain subsides when the person rests and they relax and the pain goes away, we call this stable angina. If it does not go away with rest, we call this unstable angina. Pericarditis is inflammation of the pericardial sac that goes around your heart. Often this would be seen with a patient that has a fever, or maybe the pain subsides when they lean forward or move around. So that has nothing to do with what we're looking at. Myocardial infarction would not subside with rest either, right? Unstable angina is typically a very bad sign that the patient could be suffering from an MI. So stable angina is the best answer. Let's go and submit it. There we go. 100 out of 100. EMTs, I hope this helps. And if you are looking to do any test prep, I have a solution for you. I created an online community to help EMT and paramedic students pass not only school, but also pass the national registry. On this school community, I'm calling it the Rescue Academy. We have a community board where you can go ahead and speak to other students, either if you're an EMT or a paramedic. Also, you can go ahead and go to the classroom. You can go ahead and open EMT quizzes. Today, we did my cardiology quiz. But look how many other cardiology quizzes there are. If I click medical, look how many medical quizzes there are. If you don't want to use a quiz and you want to go and do a longer test, I got those too. I got over 1,000 test questions. Look at all these comprehensive exams, trauma, operations. These all have at least 50 questions each. And the nice part is, let me show you, after you take these tests and you turn them in, there's feedback. So it explains why that's the right answer. The best way to learn is not only to read something, see something, hear something, and then do something. You need more mediums to help you memorize everything. So listening to me or watching me take an exam, I hope this helps you. Another thing I want to show you is my guidebook for the EMT. I have a book for EMT and I have one for paramedic. And I'm excited to announce that these are found on Amazon now. So if you need a book that's not your textbook, because maybe your textbook has way too much fluff, this might be something for you. There's a lot more visuals to see. There's also QR codes throughout this entire book that you can scan and watch me speak and lecture on every single subject in EMT to help you pass the national registry. If you're interested in that, I'm going to have a link of my school academy, and I'll have a link to the book in the description below. Guys, I wish you the best and good luck with everything.